Assalamu alaikum. Good evening, everyone. It is my pleasure to welcome you all to the 12th and final chapter in the webinar series, MENASO Cerebrovascular Grand Round, organized by the MENA Stroke Organization and endorsed by the World Stroke Organization and the American Stroke Association, and supported by Medtronic and Boehringer Ingelheim. The Cerebrovascular Grand Round webinar is a unique platform that provides comprehensive education about stroke, the latest stroke information regarding management, treatment, and updates. This will be an interactive session, so there will be a dedicated session for questions at the end of the lectures. So we encourage all the attendees to post their questions in the Q&A box. So now it is my pleasure to introduce our first speaker, Dr. Ammar Al-Qawi. Will be talking to us about, it's a difficult topic, 2021 major trials summary. Dr. Ammar Al-Qawi is a vascular interventional neurologist. He is currently Deputy Director of the Neurovascular Integrated Program Unit at King Faisal University, King Faisal Specialist Hospital, and Research Center, Riyadh. He is also an assistant professor of neurology and radiology at the University of Medicine and Dentistry of New Jersey, Rutgers University, and Al Faisal University. Following medical school, Dr. Al-Qawi joined the University of Illinois Neurology Training Program. Dr. Al-Qawi went to complete his fellowship, a fellowship in vascular neurology at New Jersey Medical School, Rutgers University, after he completed his second fellowship in endovascular surgical neuroradiology at New Jersey Rutgers University. He is a diplomat of the American Board of Psychiatry and Neurology in the specialty of vascular neurology. He was inducted as a fellow of American Academy of Neurology and also a fellow of the American College of Physicians. He has authored and co-authored numerous books, book chapters, and peer-reviewed manuscripts in prestigious journals. He has been invited speaker at various national and international forums. His research interests include novel imaging modalities in neurovascular surgery, particularly as it applies to the treatment of cerebral aneurysms and acute strokes. He's also a personal friend and mentor. So we're glad to have you, Dr. Ammar. The floor is yours.
Thank you, Dr. Hani, for this kind introduction. Thank you very much, Dr. Hani, for this kind introduction. I also would like to thank the MENASO for inviting me to participate in the very nice educational programs that they're offering. I'd also like to thank Dr. Suhail Rikun for his very strong efforts in the MENASO and in his region and in all of the stroke programs that we interact with as far as international meetings. So his efforts are very well appreciated. So without further ado, I was asked to give a quick synopsis of the most important major stroke trials for the year 2021. As you can imagine, this has not been an easy task. I might have actually not been able to include all of them in this short half hour, but I tried to find the studies and trials and analysis of trials that might have some kind of impact on practice. So let's start. Okay, so the most important issue that everybody is thinking about these days is IV thrombolysis, followed by mechanical thrombectomy versus taking the patient to mechanical thrombectomy directly. This is obviously for acute stroke patients. So the question is, we would like to determine whether skipping thrombolysis and going straight to thrombectomy is as good, or in other words, non-inferior to thrombolysis, followed by mechanical thrombectomy. The population we are talking about that might qualify for thrombectomy are about 1/3 of all ischemic strokes, and they involve the large vessels, internal carotid arteries, proximal M1s or distal M1s, and proximal M2s. So it actually applies to a large proportion of the patients that we see on a daily basis. So Alteplase is the agent that is most widely used right now for intravenous thrombolysis. And the pros for using intravenous treatment is it is good for small to medium clots. It works fairly quickly. It might recanalize the occluded vessel before getting to the mechanical thrombectomy. And it also possibly might make the clot more responsive to retrieval devices and mechanical thrombectomy when the mechanical thrombectomy happens. What are the cons? Well, it doesn't work very well, we know, for big proximal clots that cause the most severe strokes. And recanalization rates are not that great with intravenous thrombolysis alone. It ranges between 10 to 15, might be up to 30%, depending on the study that you are quoting. And there is obviously increased risk of bleeding because it's a systemic medication. And it also might cause actually clot fragmentation, and the clots shower distally beyond the reach of any mechanical thrombectomy device that we have. What about mechanical thrombectomies? Well, the most important devices that made a difference in this field are the stent retrievers and the aspiration devices, and sometimes a combination of both is used. What are the pros for that? Well, we know right now that they are very good and effective for big proximal clots. And the problems that we run with, that we are up against with using this modality of treatment is that they are not very good for small distal arteries because of the caliber of the vessels involved. And another layer of complication is that it is not available in every stroke center. Actually, it requires a lot of specialized expertise and multiple teams to be able to provide this kind of service. So what's the current standard of care right now? The current standard of care, any patient who is eligible for IV Alteplase within the first 4.5 hours of onset should receive the intravenous Alteplase on the way to the angio suite. All right, so let's talk about the trial right now. The SCIP trial, it's the effect of mechanical thrombectomy without versus with intravenous thrombolysis on functional outcome among patients with acute ischemic stroke. So this trial actually used 0.6 milligrams per kilograms Alteplase, which is 2/3 of the more common dose that is used. This dose actually, the reduced dose is used widely in Asia, specifically in Japan. And the trial is a non-inferiority trial. This actually, the slide summarizes the study where you have about 204 patients that were involved in the study, and they were randomized to either mechanical thrombectomy alone or mechanical thrombectomy and intravenous thrombolysis at a dose of 0.6 milligrams per kilogram. It actually was carried out at 23 hospital networks in Japan. And what they found that the outcomes, the pre-specified outcomes of modifying Rankin scale 0 to 2 at 90 days were pretty much similar between both groups, the mechanical thrombectomy alone versus the mechanical thrombectomy preceded by intravenous thrombolysis. Based on that, they actually said that it failed to demonstrate non-inferiority of mechanical thrombectomy alone compared with combined IV thrombolysis plus mechanical thrombectomy following large vessel occlusive ischemic stroke. A couple of words of note about this study. The period of time between IV Alteplase initiation and groin puncture was about 8 minutes. So the theory is that it possibly helped thrombolysing small distal fragments that the stent retrievers often left behind. The nominal rate of functional independence at 3 months was a little higher with skipping IVTPA than with not skipping IVTPA, but it did not reach statistical significance to prove non-inferiority. And that actually led to the conclusion that it was, they did not reach the non-inferiority based on this study. This leads to the second study, actually, which addressed this question as well and was published as well this year. It is the DEVT trial. It was a trial that was done in China. The title was Effect of Endovascular Treatment Alone versus Intravenous Alteplase plus Endovascular Treatment on Functional Independence in Patients with Acute Ischemic Stroke. A couple of notes about this study. It actually used the full dose of Alteplase that we know of, which is 0.9 milligrams per kilograms. It was also a non-inferiority trial. And the primary outcome was patients achieving functional independence at 90 days, which translates into a modified Rankin scale of 0 to 2. Again, this is a nice diagram that summarizes the study where they had a very similar number of patients to the SKIP trial. They had 234 patients that were randomized to endovascular thrombectomy alone or to the combined treatment of endovascular thrombectomy plus intravenous Alteplase. Given at the same rate and with the same bolus as we do on a daily basis. It involved 33 centers in China. And again, the primary outcome was the very similar outcome that we look for, which is independence at 90 days with the modified Rankin scale of 0 to 2. What they were able to find was that the endovascular thrombectomy group had 54% reached the primary outcome result compared to 47% only in the combined treatment. And therefore, the study was stopped early, and these findings were interpreted as the patients with ischemic stroke due to large vessel occlusion, endovascular treatment alone actually met versus coupled treatment with IV Alteplase and mechanical thrombectomy met the specified threshold for non-inferiority for 90 days functional independence. What was of note in this study is that the period of time between IV Alteplase initiation and groin puncture was about 40 minutes, which is much longer compared to the SKIP trial. And about 7.5% of the patients had recanalization before arriving to the angio suite. Therefore, IV TPA was given a better chance for recanalizing these clots that were amenable to intravenous treatment. The direct mechanical thrombectomy group had nominally more good outcomes than the combined IV thrombolysis and mechanical thrombectomy group, and the difference was enough to reach statistical significance for non-inferiority. This led to the conclusion that patients with ischemic stroke due to proximal anterior circulation occlusion within 4.5 hours from onset, endovascular treatment alone compared with IV plus endovascular treatment met the pre-specified statistical threshold for non-inferiority for the outcomes of 90-day functional independence. And these findings should be interpreted in the context of clinical acceptability of the selected non-inferiority threshold. What are the implications of these trials? Well, for the time being, we should continue to give IV TPA treatment to patients who present to a hospital that only does IV thrombolysis, the drip and ship approach. The time to get to the mechanical thrombectomy is specifically if the time to get to the mechanical thrombectomy is prolonged. This is for patients, who come to a peripheral hospital, and it takes a while for them to be transferred to a center that's able to offer mechanical thrombectomy. For mobile stroke unit patients, it is much more preferred to have these patients receive IV TPA because they're able to administer this within the first hour of onset of symptoms at the scene, allowing for some time between the IV TPA to work and the mechanical thrombectomy. So time is not lost in that aspect. To patients who you are not sure that the occluded artery will be reached by mechanical thrombectomy, especially if the patient has cervical carotid occlusion or have excessively tortuous aortic arch anatomy. It's reasonable to skip IV TPA if you're confident that mechanical thrombectomy can reach the clot in the occluded artery quickly. And we have been doing that at our center in some patients where you really believe that the clot burden is so large and the intravenous TPA is going to delay access to the mechanical thrombectomy treatment. I think the optimal way of dealing with that is to rush to the mechanical thrombectomy for recanalization as soon as possible. All right, so let's switch gears a little bit right now and talk about patent foramen ovale closure, decrease the incidence, but not the size of new brain infarction on magnetic resonance imaging and analysis of the reduced trial. So the reduced trial actually enrolled 644 patients. These patients actually underwent either PFO closure or were treated with antiplatelet treatment only. These patients had baseline brain MRI and had a follow-up brain MRI at 2 years, or if a clinical event happened. And they compared the incidence of new clinical stroke or silent infarction versus clinical stroke versus silent infarction between these two groups. And they found that there was no difference in the number, volumes, and distribution of the new infarct comparing closure patients to those treated with medications alone. This also shows, the number of the patients who actually had MRI analysis at 2 years follow-up. And this actually shows the incidence of the distribution of total new ischemic injury comparing baseline to follow-up magnetic resonance imaging MRI in patients who underwent closure and versus patients who received antiplatelet therapy alone. So in conclusion, the reduced trial demonstrated that patent foramen ovale closure prevents recurrent brain infarction based on objective outcome of new infarcts on brain MRI. Only clinical strokes were reduced closure, while silent infarctions were similar between study arms, and there were no differences in infarct volume or location comparing silent infarctions to clinical strokes. This is an interesting study that was just published in December, this current month, actually. It's a first pass effect in basilar artery occlusion, insights from the endovascular treatment of ischemic stroke registry. It actually looked at patients who, we all know that in the setting of thrombectomy, the first pass effect, which means complete recanalization after one pass with no rescue therapy, was shown to be associated with improved outcomes. So what they wanted, to do is to study this on the posterior circulation, because this was very well noted in the anterior circulation. They actually, it was a registry and multicenter registry, and they looked at 280 basilar artery occlusion patients who were treated with thrombectomy. And they looked at the first pass effect for those patients. The first pass patients were 93, which was about 1/3 of those, and the 2/3 actually had to have a rescue treatment for recanalization. And when they compared the clinical outcome at 3 months, it showed that the patients who had first pass recanalization did much better than the patients who had, to have further rescue treatments or supplementary treatments for recanalization of these occluded basilar arteries. This was a schematic of how they analyzed this is the modified Tiki classification for recanalization, and they compared the patients who had first pass versus patients who didn't have first pass. And this again actually is the Grata bars that showed the improved clinical outcomes for the patients who had first pass. So in conclusion, they actually concluded that a first pass effect was achieved in 2/3 of the patients with basilar artery occlusion and was associated with a significantly better outcome and lower mortality. Non-erythematous etiology and use of supplementary recanalization treatment were strong predictors of first pass effect. Further studies are necessary to confirm these findings. All right, move on to endovascular thrombectomy for treatment of acute ischemic stroke during pregnancy and the early postpartum period, which is an important clinical question. This was a study that actually looked at patients who it also actually is at a single center where they compiled all of these cases. What they were able to find that among, it is not very well known whether, these patients should have recanalization versus via mechanical thrombectomy, especially with them having a pregnancy on board. So what they did was that they actually looked at this from 2012 to 2018 to identify and characterize pregnant women and postpartum patients with acute ischemic stroke treated with mechanical thrombectomy. They were able to identify 4,590 pregnant and postpartum ladies with acute ischemic stroke. Of those, 180 underwent thrombectomy. 50% of them were discharged home. They had 0 mortality, 11% intracranial hemorrhage, and 0 decompressive hemicraniectomy. So they also compared the effect of mechanical thrombectomy trials on the numbers of and the rates of the mechanical thrombectomy utilized for these patients. And actually, as expected, there was a big jump of utilizing these treatment after the publication of the studies that showed that mechanical thrombectomy was very efficacious. Their conclusion was that for patients with mechanical thrombectomy during pregnancy, the cross-sectional analysis utilizing National Registry data evaluates treatment of acute ischemic stroke with endovascular thrombectomy in the setting of pregnancy and postpartum period. The findings suggest that it is a viable and safe first-line therapy. And because this is such a rare occurrence in this population, prospective study is going to be difficult, but what they're saying is that they're trying to arrange a large-scale cross-sectional analysis to try and accumulate the data and get more results. This is a quick study, effect of baseline cognitive impairment in patients with asymptomatic carotid stenosis in the CREST-2 trial. They found that the patients who had asymptomatic stenosis did worse as far as cognitive function. And, although these patients had asymptomatic carotid stenosis, but actually their cognitive function was affected, especially memory, rather than other higher comparative functions. So this is something actually to keep into consideration. The asymptomatic carotids that are stenotic might not be asymptomatic after all. I'd like to talk a little bit about prospective multi-center control trials for mobile stroke units. This actually made a big impact when it was published in September 2021. The mobile stroke unit is basically an ambulance that has a CT scanner, and you're able to provide point of care testing labs like INRs and glucose. And you have people who are trained in stroke treatment on board the ambulance. They compared whether patients who were transported via mobile stroke units compared to standard EMS care. Is there any difference in stroke outcomes? It was a prospective, multi-center, non-randomized, alternating week, cluster-controlled trial. The patients received emergency care within 4.5 hours after symptom onset, and patients eligible for TPA treatment received TPA. They actually randomized them to, depending on the week, they were enrolled in the trial, mobile stroke unit versus EMS regular. What they found actually was that on the Grota bars that there was a clear improvement in functional outcome for the mobile stroke patient units compared to the emergency medical services as far as modified Rankin scale 0 to 2. They also utilized something called a modified Rankin scale, utility-weighted modified Rankin scale. Anything below, anything above 0.91 is complete recovery. And what they were able to see was that the patients with a mobile stroke unit much better as far as outcomes compared to the patients who had standard EMS care. The average time for receiving IV TPA was 72 minutes in the MSU care group compared to 108 minutes in the standard EMS. And these are the times that were published in the article. The symptomatic intracerebral hemorrhage was very similar, and the patients' the mortality at 90 days were much better in the MSU group compared to the standard EMS patients. So it's associated with less disability at 90 days and less mortality compared to the EMS, to the regular EMS service. Quick move to Ticagrelor versus Clopidogrel in patients who have CYP2C19 loss-of-function carriers with a stroke or TIA, the CHANCE-2 trial. What they were able to find was that Ticagrelor was non-inferior compared to Clopidogrel when given to patients with resistance to the Clopidogrel activation. We all know Clopidogrel is a prodrug that requires the CYP2C19 for activation into an active metabolite. Ticagrelor actually is an active metabolite, which does not need to be metabolized. So the risk of severe moderate bleeding did not differ between the two treatment groups, but the Ticagrelor was associated with more total bleeding events compared to Clopidogrel. Depression outcomes among patients treated with fluoxetine for stroke recovery, the Affinity randomized clinical trial. What they found was that patients who received 20 milligrams of fluoxetine that were initiated within 2 weeks of acute onset of symptoms of stroke did not do any different than the patients who did not receive fluoxetine. Therefore, routine daily treatment with 20 milligrams of fluoxetine did not decrease the proportion of patients affected by clinical significant symptoms of depression after a stroke, nor did it affect proportion of people prescribed an antidepressant or receiving non-pharmacological treatments compared with placebo. We all know that about 10 years ago, there was a publication that suggested improved motor functions in patients who were treated with fluoxetine in the acute setting. Therefore, they suggest that patients should not be treated routinely with 20 milligrams of fluoxetine to prevent or treat clinically significant symptoms of depression during the first 6 months after the stroke. Let me see here. Okay. Second asymptomatic carotid surgery trial randomized the comparison of carotid artery stenting versus carotid endarterectomy, the ACST-2 trial, where they randomized the patients to carotid artery stenting versus carotid endarterectomy. This has been a hot topic for a long time, and they compared the patients' outcomes. We all know that actually with the time, the carotid endarterectomy technique has been pretty much didn't change a lot, but the carotid artery stenting tools and utilization of catheters have improved dramatically. So what they were able to show, make a long story short, that pretty much both modalities are comparable for treating the carotid artery stenosis, and both are pretty much acceptable with similar outcomes and similar side effects. And with this, I think my time is up. Am I correct on that?
Yes, exactly on time, Dr. Ammar. Thank you.
I tried to rush through the last few slides because of time, but excuse me for that. You know, there's a lot to cover in such a short time.
Dr. Ghani, we can move on to the next speaker.
Yes, I did something I can see. Okay, just a second. Okay. Okay, now we move on to the second speaker. It is my pleasure to introduce Dr. Adari Salmin. She will be talking to us about ESUS, what is new. Dr. Adari Salmin is a stroke neurologist at Jaber Al Ahmed Hospital, Kuwait. She is also a clinical tutor at the Adult Neurology Residency Program in Kuwait. She is also a member of Thrombectomy Committee in Ibn Sina Hospital and Director of Stroke Committee at Jaber Al Ahmed Hospital. She graduated from the Faculty of Medicine in Kuwait and completed her Adult Neurology Residency in University of British Columbia in Vancouver, Canada, followed by Stroke Fellowship at Vancouver General Hospital, British Columbia in Canada. She is currently holding a membership in Kuwait Medical Association, European Stroke Organization, Canadian Stroke Consortium, and Kuwait Neurology Society. She has authored many scientific publications and presentations. She has been an invited speaker at various national and international forums. Dr. Adari, the floor is yours.
Hello, everyone. Thank you again for the invitation to be part of the Cerebrovascular Grand Round of MENASO. My topic today will be regarding ESUS, what is new. I have no disclosures. In summary, I'll briefly discuss the definition of ESUS and what we understand so far from the likely underlying mechanism and accordingly the management. We'll start with the definition. So from before, we knew based on TOSA classification, even before that, there was this subgroup of stroke that we don't really understand the underlying etiology. According to TOSA classification, they mix them along with those who have had incomplete evaluation and those who have had more than two causes identified. In 2014, Dr. Hart and his group in ESUS International Working Group, they came up with a new definition of ESUS. The focus mainly has been for those with non-lacunar brain infarct on imaging, those who have had open arteries, so technically no significant stenosis proximal to the area of the stroke, and there are no major risk cardioembolic sources. So eventually we understood that ESUS is really just a subgroup of cryptogenic strokes, those who have no underlying etiology. So cryptogenic strokes, we say usually it counts for about 25 to 40% of all strokes. And again, those are strokes that are not attributable to a definite cardioembolic, large artery, athero, small artery, or other identifiable causes. Regarding with ESUS, the percentages, it has been ranging from 9 to 25% of all strokes. But those strokes predominantly have been embolic. So we're not looking for those subcortical. We're looking for something larger than 1.5 centimeter on imaging. On top of that, we don't need to have any other etiology. So technically, again, absence of proximal stenosis, no atrial fibrillation or other major risk cardioembolic source, and no other likely cause identified. The workup or the assessment required to have a final diagnosis of ESUS, however, has been quite limited. So technically, we're still going with the basics, starting with the brain imaging, CT or MRI, 12-lead ECG, transthoracic echo, cardiac monitoring of 24-hour or more, and imaging of both extracranial and intracranial arteries, whether with ultrasound, CTA, MRA, or with catheter. One of the largest ESUS global registry, they kind of like included 20 stroke research centers in 20 different countries, and they tried to identify the data of those patients with ESUS. So they identified 2,144, so that's about 19% from the total stroke patients that they have. The mean age was 62, so technically they are youngish population. They tend to have minor strokes with a median NIHSS of 4 in this registry. They have a low 30-day mortality compared with the rest. Interestingly, when they tried to see what is the likely potential etiology of their stroke, 74% have identified at least one minor risk embolic source. And in 24%, they have identified 2 or more potential sources. Another interesting point that PFO only made 25% of those cases who went for TEE. So we know that those patients technically have, like the younger age, the milder stroke, but their stroke recurrence rate is actually not very benign. It has similar to those of cardioembolic. It's about 4.5 for the estimated annual stroke recurrence risk, in spite of having just a low mortality rate compared with the usual cardioembolic stroke. Going for the underlying mechanism, the overall theory has always been this is embolic, and it came around the same time where there has been a lot of focus for looking into the subclinical atrial fibrillation, the covert atrial fibrillation, the loop monitor, extensive workup for those as well. So that has been one of the major focus of ESUS. The potential etiology was likely to be a cardioembolic. In addition to low ejection fraction has been studied, the silent MI as well. With the atherosclerosis, the focus has been mainly for those with non-significant stenosis of carotid artery. Now, keep in mind, those, like looking very, very back with the MENASO trials and what so, those did not have any benefit when they went for the surgery, and for the asymptomatic, technically, they were not even included in those trials. In addition to intracranial atherosclerosis, aortic arch, other etiologies identified such as cancer and certain vasculopathies. But the list is really longer than just those etiologies. I will focus mainly on the most common mechanism for cardioembolic. So from a previous gene expression profile studies, they identified that cardiogenic embolism accounted for about 58% of cryptogenic strokes. But again, this is not just a covert atrial fibrillation. There has been some valvular disease, other arrhythmias in atrial fibrillation, structural etiology, left ventricular dysfunction, paradoxical embolism on top of the cancer-associated and the arteriogenic emboli. Now, AF detection, it has been a hot topic from before with Crystal AF, Embrace, Assert, all those trials, they kind of found that if you look for AF very hard, you will eventually find this AF. So AF was detected in about 30% of ESUS strokes during the long-term follow-up. But is it really the underlying etiology of the stroke? This is still a bit of a dilemma. We don't know exactly what is the specific duration required for AFib to say this is responsible for a stroke. If AFib being subclinical is similar to those who have had symptomatic one. If it's detected long after a stroke, is it the same as those who have been detecting shorter after the stroke? So the whole picture has been still not 100% clear. Do I still need the 6 minutes or is the 30 seconds okay? And we're looking now into the previous studies. Is it really a causal? So one of the studies, I think it was like the beneficiaries Medicare, they identified that AFib after ischemic stroke tend to be more common than AFib after hemorrhagic or after admission for non-stroke. So there is some sort of relationship, but is it really the cause? We don't know 100% because we know that with ESAs being a 30% identified if you actually look for it. There is a stroke AF trial as well, where they looked for AF in patients who already have a known etiology of their stroke. So they looked into the population of large artery and for small vessel, and they did find the incident of atrial fibrillation to be higher than with control. This is one of the most recent publications, the loop study. So what they did here, this is not specifically for ESAs, but they did the implantable loop recording for those who thought to be a high-risk population. So that's usually age, like the inclusion was for age 70 to 90, and they would have one more extra risk factor. So it would be diabetes, hypertension, previous stroke, or heart failure. Those population who went for the ILR, they had higher chances of detecting atrial fibrillation or being treated with oral anticoagulation. But if you look at the incidence of a stroke or systemic arterial embolism, it did not really help much with preventing them. So now we know that technically I can detect the atrial fibrillation, I can treat it, but it does not necessarily mean I'm going to actually influence the future risk of stroke. Now, because it's only 30% of ESAs have been related to atrial fibrillation, the idea from this trial, the AF ESAS score, is to come up with the higher risk population to identify them, that those are likely the ones that we need to look very hard for underlying atrial fibrillation with them. So they went into 3 large registries. From those, they have identified 839 patients with ESAS. From those population, 43.1% were women. The median age, again, seemed to be young, 67 years old. The follow-up was about 2 years. And 40.9% had a new incident of atrial fibrillation. Again, this is another interesting point because majority of those atrial fibrillation actually were diagnosed based on routine 12-lead ECG. So they did not really undergo the prolonged cardiac monitor. The 24% were regarding a telemetry for hospitalization for stroke recurrence. So that's another stroke. 14.4% for the repeat Holter. And the remaining had been for those who have been admitted for other etiologies than stroke and for the prolonged cardiac monitor. And of course, those who have had atrial fibrillation were the typical population that were older, higher prevalence of hypertension, diabetes, coronary artery disease compared to the patients without. The score that they came up with, they took into consideration age being 60 or more, arterial hypertension, left atrial diameter more than 40, any supraventricular extrasystole, so those will kind of add on points, and then they would take off points if there was a left ventricular hypertrophy, left ventricular ejection fraction less than 35%, subcortical infarct, and non-stenotic carotid plaque. And the idea is that those probably have a different underlying mechanism than atrial fibrillation. The median score has been around 2, and those who have had a new atrial fibrillation have had a median score of 5. So based on this study, those who have had a score more than 0, 26.9% have had a new incident of stroke compared to 1.97% for those who have had a 0 score, with a sensitivity of 94.9% and negative predictive value of 98%. So this is something to take into consideration if there is certain limitation in the work that we can do for the loop monitoring if I cannot provide it for all patients with ESAs. This can help us in limiting those resources. My next point here is just regarding PFO. So PFO has been considered part of ESAs, but we know from the positive trials from 2017 onward that it is actually a specific entity. It does need a bubble study, which, if you remember, was not included as part of the workup for the ESAs classification. And closure of the PFO is associated with reduction of future strokes. Now, briefly, we'll talk the arteriogenic. So non-stenosing or non-significant stenosis of the carotid plaque. So those are the less than 50%. Now, remember from Navigate ESAS that those patients more likely to have those non-stenotic carotid plaque ipsilateral to their stroke. Those who have had the ipsilateral carotid plaque were less likely to have atrial fibrillation detected. And those also who have had this carotid disease seem to be less likely to have the PFO. So those are kind of like pointing toward the carotid being a likely mechanism, or there's a likely association between it and those ESAs strokes. Regarding aortic arch atheroma, we knew from before that this has been associated with stroke, but there has not been a strong focus on it. The CTA or the TEE is not routinely ordered for all patients to rule out aortic arch atheroma. And this is mainly because we don't have a positive study that says if I catch the aortic arch atheroma, the treatment will be different. Regarding others, I'll mainly talk about the cancer-associated ischemic stroke. So patients with cancer seems to have a higher risk of stroke compared with the general population. This is thought to be either related to merantic endocarditis, hypercoagulability, paradoxical source, tumor-related vascular compression, or from anti-cancer treatment itself. Canadian stroke best practice recommended that those patients should undergo the standard etiological workup. There is no specific way or test that I can say 100% that that stroke is related to the active cancer. Some studies did focus on doing a D-dimer, with a high D-dimer making this stroke likely related with the underlying cancer, but we don't have a specific cutoff to say that above this level is significantly associated with cancer. And we also have to remember that stroke has also been identified about 3 years prior to occult cancer. So technically, in certain populations with ESUS, we can include potentially like a cancer malignancy screen workup if we want to identify the exact etiology of their stroke. Now, how do we treat those patients? It is still unclear. There were 2 small trials that tried to look for anticoagulation with ESUS and cancer to see if it was beneficial. Those were not positive. I know there are some ongoing trials still to look specifically into this. According to Canadian stroke best practice, it is to be considered to give anticoagulation, specifically lower molecular weight heparin is the preferred agent. Now, regarding to management, just a quick reminder from what we said before from AF, ESUS, and others, that those patients can have potentially more than one embolic source identified. In fact, about 30% of those will have 3 potential embolic source or more. And this is why there cannot be one specific treatment that we can use to target all those population. You can see based on the potential etiology, some patients would respond to anticoagulation, other would respond to antiplatelet rather than anticoagulation. And there are those populations that would have more than one underlying etiology identified. This is just an overall picture of how we have always approached the stroke. So from previous trials that looked into warfarin for non-cardiac origin strokes, we know that it was not positive trials, that warfarin with therapeutic INR compared with aspirin did not add on any specific benefit, and there was a risk of bleeds associated. Socrates is one of the trials that looked into ticagrelor, and there was a subgroup where they looked into the low-grade carotid stenosis and severe aortic arch, and they didn't find those patients who have taken ticagrelor early were associated with reduction in the recurrent ischemic stroke. Chance, Point, Tails, all those trials that did the dual antiplatelet also have shown positive influence for those with intracranial atherosclerosis. But we have to also keep in mind that Chance and Socrates actually enrolled their patients early. They did the 24-hour window for enrollment. So this is also something to take into consideration when we try to plan a future ESUS trial, because those 2 are the main big ones that looked into NOAC and ESUS. We have Navigate ESUS that use rivaroxaban 15 milligram once daily, and Respect ESUS that use dabigatran 110 or 150 based on the patient's age and creatinine clearance. The age classification for inclusion has been more than 50 for Navigate, and for Respect has been more than 60. Now, time from stroke to enrollment has been up to 3 months. Now, remember with the dual antiplatelets trial, they were actually quite aggressive with doing only 24 hours window. The definition of ESUS was similar to the one that we just used, except that Navigate ESUS did not actually mandate that those patients have intracranial vascular imaging. Based on the studies, the population that they have was about 3,600 for Navigate, for Respect 2,695. The mean age, again, they're the young population, 66.9 and 64.5. Majority have been male. Hypertension has been predominant, diabetes about 20 to 25%. Interestingly, PFO has been present in about 7.1% in Navigate and 12% in Respect. Keeping in mind that Respect actually included those above 60 years of age. The median NIHSS in Navigate was 1. So again, those are the minor strokes we were talking about. And the median time from qualifying a stroke to randomization has been about 38 days. In those trials, both of them, they did not find that anticoagulation actually showed any benefit in recurrent ischemic stroke. However, it did show increase in the hemorrhagic strokes. The main feedback has been with those guidelines was regarding the time for enrollment that was higher than anticipated. Navigate used 15 milligram of rivaroxaban dosage instead of the 20 that we tend to use for the anticoagulation for AFib. So why those trials have been in neutral? Probably because of the heterogeneity of those mechanisms like we discussed earlier with those population. So we already identified that those patients will have potentially more than one source identified. And we know that those approaches for red thrombi is different from those of white thrombi. So technically red thrombi means it's probably a proximal source, cardiac-related atrial cardiomyopathy, left ventricular disease, PFO, and cancer. White thrombi, those that respond to aspirin, so those tend to be related more so to the atherosclerotic changes. And the thrombi has been even a hot topic now with the thrombectomy, just because of the approaches of how to approach them and how much this will actually influence the success of the procedure and the outcome as well. In one paper, they kind of tried to see if there's anything extra I can do that will help me be more certain if this is the cardioembolic source or arteriogenic. So those dependent on MRI. Initially, if you remember, we said we can either use CT or MRI. But the beauty about MRI is it can help us identify those silent small lesions, if there are multiple lesions, and those remote and new. So it will give you an idea of what is going on exactly within the brains. So technically, we no longer use the size and shape to say what is the likely underlying mechanism. Looking at picture A, for example, you have a left and a right stroke. So this cannot be a large artery disease, right? Because it has to be proximal. You cannot blame one carotid for both hemispheres. Looking into picture B, this is likely a subcortical small lesion. Picture C here, all those DWI lesions have been within one vascular territory, making it more likely to be a carotid rather than a proximal source. We do have some ongoing trials to look specifically for for DOAC and ESAs, Atticus and Arcadia. I know Atticus was recently stopped due to futility of the result. Arcadia is still ongoing, and we have even more studies ongoing to see if there are specific markers for those that we think are likely related to atrial fibrillation or to a cardiac source, with anticoagulation, NOAA being one of them, because now the idea has been that atrial fibrillation is probably just a marker of some sort of underlying atrial cardiopathy that we are still trying to understand. Again, this is not an ESAS trial. This COMPASS was technically like a primary cardiovascular prevention kind of trial, but they did include patients who have had peripheral artery disease, and those were defined to either have like a peripheral vascular disease or carotid disease. Those patients did not have any history of recent stroke. The exclusion criteria was for having a stroke within the past month. But those population actually did benefit from the low dose rivaroxaban plus aspirin. The low dose was 2.5 plus aspirin. It did lower their primary outcome of cardiovascular death, stroke, and myocardial infarction, coronary heart disease, death, myocardial. All those has been significant. Looking at mortality specifically, it was not significant. For the pre-specified limb outcome, again, the major adverse limb event has also been significant. So it kind of also opens the door if there is any role for using something similar to what the regimen was used in COMPASS for those with the non-significant stenotic carotid. What we have currently from guidelines, from Canadian Strong Best guidelines that were published looking into ESAs last year, they are still not recommending anticoagulation. We are still going with the usual antiplatelet for those. Similar thing with the AHA-ASA guidelines published this year for stroke prevention. Still, DOAC is not recommending over antiplatelet. Ticagrelor specifically is still not recommended to reduce secondary stroke prevention for those with ESAs. One thing to take into consideration now that we agreed that ESAs is probably not a single entity, but a multiple entity, that maybe we need to change some of the approach that we have been using to reach that diagnosis from that basic workup that we are used to doing, because we know that, for example, TEE will give you more information than TTE. We know that if you look into the intracranial vessels, it will give you better pictures of what is going on exactly. We know that CTA, MRI, or MRA will give you a better picture of the vessels than if you just do an ultrasound. So some of the workup can be further utilized to help out. And then accordingly, we also know some of those non-common etiologies, and accordingly, we can define them. So PFO now, we know that we usually can get ahead with it with just a bubble study, but we have other causes as well that would require specific features. For example, if you have a high risk for dissection, if there is anything to suggest vasculitis, infective endocarditis, was the stroke in an arterial territory to make you think of CBST, for example, toxicology, screen, all of those things. So it's really just a matter of the workup that you do to reach the exact etiology. So in conclusion, ESAS is a heterogeneous group. It's not really a single entity. According to the underlying potential source, the management can be tried accordingly. There may be more than one potential embolic source, which can complicate the picture of what is the best medical management. It just emphasizes that this is in fact a heterogeneous group. Utility of advanced diagnostic techniques, better criteria for clinical assessment to help us identify the likely underlying source. And eventually, we do need more subgroup trials and potential redefinition of ESAS to reach a better control and better management of those patients. Thank you very much.
Thank you very much, Dr. Adari, for a very comprehensive review and nice presentation. Now I'd like to invite both amazing speakers to answer some questions. Dr. Ammar, are you with us?
Yes, I am. Yes.
Okay, great. Okay, so I have some questions. Yes, I have a question for Dr. Ammar. Okay, so the trials you've mentioned, they all used TPA or Alteplase. What about Tenecteplase? As you know, it is given as a bolus and it's quick. So has it been involved, I mean, or used in some of the trials, making it easier to give, on their way to mechanical thrombectomy?
Yes, actually, the Alteplase actually it's a very good question. That's why I alluded to in the slides that I presented. I said, for the time being, the most commonly used agent is Alteplase, but Tenecteplase actually is making its way more and more as an alternative, and it's a pretty good alternative. The benefits for using Tenecteplase is that it is given in a single bolus, so you don't have to worry about the infusion, which actually is a lot of manpower work. Actually, if you look at the nitty-gritty details for thrombolizing in an acute setting. And also it is more fibrin specific to the fibrin bound clot. So it gives you a little bit of more effectiveness for the clot that is, the target of what you want the agent to work on. They have not looked at it in the setting of mechanical thrombectomy, so they didn't compare Tenecteplase with mechanical thrombectomy to Tenecteplase without mechanical thrombectomy. I didn't come across anything like that. But it made its way through protocols. For example, in Australia, actually, they have already switched, a lot of centers actually have switched to Tenecteplase and, from Alteplase. So it is a very promising agent for IV thrombolysis. And, it might make things a little bit easier logistically to administer to patients. Yes.
Fantastic, thank you. For Dr. Adari, there's a question about COVID. There must be some questions about COVID. Is there any correlation between COVID and embolic strokes?
Yes, definitely yes. So again, we don't have a specific definition when we can say this stroke is 100% related to COVID. You kind of just look into the overall picture, the overall workup. If you don't have an underlying cause identified, this stroke does seem to be embolic. Then you look into the severity of the COVID, you look into the inflammatory markers that they came with, so LDH, CRP, D-dimer, that sort of thing. All those have been high, then this stroke is likely to be related to COVID. Again, presumably the rest of the workup has been negative. I know some centers, at least even in my center, we had some limitation in completing that workup early to say that this is a 100% COVID related. Like, for example, ordering Holter has not been very easy for our COVID patients. It had to be as an outpatient after they clear from COVID. So the management at that point has been a little bit challenging on what we do with them, but the the overall theory was that this was likely to be COVID related if those inflammatory markers had been high, and the echo did not really show anything to make me suspicious that this is likely an atrial fibrillation stroke.
Thank you. For Dr. Ammar, one question. In patients above 75-year-old, so there's a question, which is better, endovascular therapy versus TPA versus mechanical thrombectomy?
This is actually a nice question. We do not make an age distinction for how to treat patients. Patients who actually present with an acute ischemic stroke, if they have a large vessel occlusion and if they present within the time window for IV TPA, they have no contraindications for intravenous thrombolysis, they receive that. And then if they have a very good indication for mechanical thrombectomy, they go for it. We do not make a age cutoff for distinction, whether, to treat the patients above 75 or octogenarian patients, differently than you treat patients who are younger. But as far as if you ask me about outcomes, how do outcomes, look like for patients who are above 75 compared to patients who are less than 75. I haven't come across any study that compared, dissecting these two populations and you have to keep in mind, you have to actually compare them with making all of the other variables, similar. Size of stroke, location, baseline modified Rankin scale, and all of that. So it's not easy to do. It's more of a statistical trivia kind of information. But for me, I don't make a age cutoff or an exception for patients who are younger than 75 versus older than 75. Mind you, patients who are younger in general do better. And we feel the urge to be more aggressive in these patients because usually their recovery is a little bit better compared to patients who are older. But that doesn't change my decision making as far as treatment goes, based on the age only.
Okay, perfect. Thank you. For Dr. Aydari, another question. For how long low molecular weight heparin given in stroke patients and have cancer as well?
Okay, so technically, first, let's remember this is not just a stroke neurologist decision. This is a multidisciplinary decision. So it's a neurologist plus the oncologist, and sometimes even the hematologist is involved in those. The overall theory is that we give it as long as we think the precipitating cause is present. So as long as they have active cancer, they will stay on the low molecular weight heparin. Some hematologists outside guidelines will even go with DOAC because there has been proven for DOAC for venous thromboembolism associated with cancer, and they think it's safe, it's acceptable for them, so they are feeling comfortable with it. So for duration wise, I would go as long as the cancer is active, presuming that there are no increased risk of a bleeds. Like CBC has been filed, coagulation profile has been filed. It is not contraindicating anything from their management.
I see. Thank you very much. For Dr. Ammar again, regarding PFO, does the treatment depend on the size?
Sorry. Okay. Treatment doesn't depend on size per se. Actually, we look at multiple factors. First of all, I look for other obvious causes of a stroke. If I'm only left with the PFO, then I look at something called the ROPE score to see what is the likelihood that this PFO resulted in that kind of a stroke. I also look for any kind of association of venous deep vein thrombosis events, especially in the legs, to try and entice me to make a decision whether to close the PFO or not. The size is one factor, and you also have to take into consideration shunting through that PFO. Is there any shunting from right to left or not? For the few patients that we have made a decision to send them for PFO closure, I have had, luckily, alhamdulillah, good results with these patients. But size is just one factor.
Excellent, thank you. For Dr. Aydari again, there's a question. In patients with ESUS already on dual antiplatelets, is it justifiable to start anticoagulation if it wasn't clear? I mean, still the source.
No, technically, we just said like guidelines do not recommend anticoagulation. And the two big trials that looked specifically for anticoagulation in ESUS were not really positive. There may have been some sort of a trend for certain patients. Like I know there was a subgroup with Navigate ESUS with the patients for low ejection fraction that they found that there may be a benefit for those patients. But overall, we would probably just continue with the antiplatelet at the time being. The dual antiplatelet, if they have like not just for ESUS, but they have something else going on. For example, if they had the minor stroke that we were just talking about based on Thales point, that sort of thing. If they have that carotid disease that we think is a bit active, ulcerated, ugly looking, dissection, that sort of thing. I would not put dual antiplatelet only because this patient came in with ESUS, but definitely no anticoagulation for ESUS in the time.
Okay, thank you. Another related question, is there a place in ESUS for aspirin, dipyridamole?
I feel like dipyridamole is like a vascular surgeon favorite. I don't know any stroke neurologists who actually like to use it. Remember, dipyridamole is one that you like. There are evidence that it works for stroke as antithrombotic, but it's a twice daily. We can barely convince our patients to take aspirin once daily, let alone to switch them to something twice daily and expect them to be compliant. It works for stroke overall, not specifically for ESUS population, just like for stroke prevention for those who do not have an indication to go for anticoagulation as an alternative to aspirin or to Plavix monotherapy.
Okay, very good, thank you. Another question for Dr. Ammar. The question is, I think, is it worthwhile having a mobile stroke unit, or what do we need in our region, and what do we need to achieve that?
Okay, the mobile stroke unit actually introduces an additional depth in penetrating the burden of the disease, where you can actually take the facilities of the hospital out to the field to try and provide care to the patient rather than wait for the patient to arrive to the hospital to provide this care. You know, I think it does a huge service for a large country that has a rural area, where you're able to take these services to that rural area and make a quick decision whether this is a hemorrhagic stroke versus an ischemic stroke. Also, if it turns out to be an ischemic stroke, right now with the huge advance in technology and the 5G connections, where you're able to be connected through an excellent connection with live transmission, and you're able to have telestroke services on board of the mobile stroke unit, and you're able to make a decision whether the patient should be thrombolized with IV TPA or you know, Alteplase versus Tenecteplase by the time until he receives until he actually arrives to the comprehensive stroke center. So actually it does add to providing the services to this certain population. The problem with it is that it is expensive, and you have to train a lot of personnel actually to be able to function appropriately. Mind you, when the CT scan is functioning, the truck or the ambulance that has a CT scan has to stop on the side, completely stop and do the CT scan and then continue moving on. But overall, actually, the huge difference and huge improvement in providing the stroke care is because you're getting to the patients earlier and you're administering the thrombolytic treatment in the golden hour, if you will.
Great, thank you. Another question for Dr. Adari. Is there a relationship between COVID vaccines and stroke?
Yes, now we know. So with COVID vaccine, there has been a lot of early talks and all, but now we know that there is something similar to ITP that happens related with COVID vaccination. And initially they said only Oxford and then Johnson & Johnson, and then different vaccines have been involved. What happens is something similar to HIT. So they come in with low platelet count. They come in approximately within the first month of having that vaccine. And it's usually a venous thrombosis stroke. It's usually not an arterial stroke. So management-wise for those patients is like they will still get the anticoagulation similar to the way you usually treat CVST, and then we add to that an IVIG. And the prognosis specifically for VIT CVST is not very much different from those who have had CVST not related to the vaccine.
See, thank you very much. See if we have more questions. Okay, another one for Dr. Adari. If patient known to have heparin-induced thrombocytopenia, what anticoagulants is substitution?
So pretty much you just stay away from the heparinoid, right? There's usually Agraban, I believe, and then another one, I don't remember the exact trade name of it. It has a B, that's all I remember, I'm afraid. But again, this is not a one-person decision, a similar thing. You also have to include the hematology to help you out, because there's more than just one factor that plays a role on what the exact choice, and depends on the cost of it and where you are exactly and what's available. But definitely the ones you stay away is the heparinoids ones.
Okay, thank you. Okay. I think all similar questions. Is it safe to use IVIG in patients with CVS?
IVIG in certain population can cause strokes. We always warn patients that it is possible. It depends what is the reason for using this IVIG. If we're looking for like the VIT, then yes, because technically we think it is immune modulating, so it is helpful in treating those patients. If a patient has had a stroke, I would care when did this stroke happen and what is the underlying mechanism I think of this stroke. If I can find an alternative to IVIG, like for example, if this patient will qualify for going for a plasma exchange, I would probably prefer plasma exchange in that situation. But if it is a definite IVIG, I don't have an alternative. It's just like a matter of outweighing a risk and benefit. It's not an absolute contraindication to give IVIG for a patient with a stroke, with history of a stroke.
Okay, fantastic, thank you. Let's see, any more questions? Okay, there's another one. Can we use small dose NOAC with aspirin in patients with AF cardiomyopathy and MCS stenosis?
Those are a lot of causes for stroke. But the bigger one is, you said AFib, one of them, right?
Yes, it says
Yeah,
AFib,
once you have an
cardiomyopathy, and stenosis.
Once you have an AFib, then you will go with the full dose. I know cardiology did this trial where they did like a subdose for the rivaroxaban and they thought it was safe, but technically they looked for safety. They did not look for prevention of stroke. So one of those trials was actually using apixaban full dose. So we're okay with giving apixaban full dose for those patients that we think is safe if they want to mix it with something else. But if patient has atrial fibrillation, I would probably recommend a full dose anticoagulation regardless of the others.
Thank you very much. Okay, I'd like to thank the speakers for amazing presentations and answering all of the questions. We'd like to thank the MENA Stroke Organization, MENASO, and all the support from MCO and Boehringer Ingelheim and Medtronic for this webinar. And thank you for all the participants. Dr. Suhail Al-Rakan, thank you for the invitation and the organization. Thank you very much. Some interesting statistics. As you know, there has been 12 grand round webinars from January to December 2021. Been very fruitful and rich, with presence of 17 scientific committee members, 60 MENA regional speakers, and 10 international speakers, with over 13,000 participants from 78 countries. So it has been really amazing year, in spite of the challenges, and hopefully the next year will be even more participants and more topics to discuss. Thank you very much. Dr. Ammar, Dr. Adari, thank you very much.
Thank you very much, and nice to see all of you.
Good to see you.
شكرا جميعا، شكرا شباب، شكرا دكتور عذاري، شكرا هاني عمار.
Okay.
Thank you, Dr. Suhail. Thanks for the invitation.